the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Hello, listeners. Before I get rolling with today's podcast, I wanted to tell you a couple of things. This goes back to my podcast a couple of weeks ago regarding the AMA scope creep. Did you know that the AMA opposes and is fighting legislation regarding the name change to physician associates? If that's not bad enough, did you know they're also fighting the ability of PAs to switch specialties? Got your attention now? Please stay tuned on these subjects after this next announcement. So, I just got back from Nashville this weekend and we had an exceptional meeting. It was great to see some old friends and reacquaint with some new ones. I'm quite proud of where we are as an organization. We had multiple research projects and poster presentations, several outstanding guest speakers, many workshops, and an overall fantastic learning environment. I want to say thank you to all of those who came to support us in our organization, and I hope your experience was exceptional. We look forward to hosting next year's annual meeting in Las Vegas. I also want to tell you that registration is open now for the Orthopedic Boot Camp, November the 8th through the 10th in Charlotte this year. Please go to the paos.org website for details and register soon. The spots will fill up quickly. We've expanded the offering this year and we'll have updates as we go forward. I can tell you there will be quite a few more workshops and lectures than in previous years, and this will be a great time for our younger colleagues in their first few years of practice to learn new skill sets and to hone in on their skill sets. I hope to see you there. Okay, back with the content from the podcast. 2 weeks ago, I had just started researching the AMA Scope Creep campaign, and I hope you had a chance to listen to that podcast. The opinions I listed were my own, but after meeting with people in Nashville, including representatives from the AAPA and the NCCPA, as well as multiple colleagues from across the nation, and hearing all of their concerns, I thought we needed a follow-up. So here's a little deeper dive into the Scope Creep campaign. Please take the time to listen to it all the way through. First, let's get a little history of the American Medical Association, which I'll refer to as the AMA. The AMA is classified as a 501c6, which means it is exempt from federal income tax. It also has approximately 270,000 members, depending on what resource you look at. This is out of over 1 million physicians in the United States. This number includes student members, retired physicians, and I don't know how many of those members are actively practicing physicians, but I suspect it's less than the overall number. The tagline on their website is that they fight for physicians. They also discuss top priorities, including Medicare reform, reform of prior authorization requirements, stopping scope creep, and dealing with physician burnout. I would like to address these issues from my perspective as I move forward. Again, I'm stating my opinions, although much of this information I pulled from the AMA website and others. So, the AMA is a huge, emphasis on huge, lobbying organization, and that is an understatement. It's in the top 5 organizations as far as money spent on lobbying efforts. Depending on the year, this typically is about $20 to $30 million. According to the AMA website, about $4 million in grants were given to state medical societies and national medical associations last year to fight scope creep. If you look at their balance sheet from 2022, they had over $1 billion, that's with a B as in blue, dollars in assets and made almost $450 million in revenue. Expenditures were higher than that, so net income was about $80 million. These aren't the exact numbers, and I don't really want to slog through those details and get nitpicky, but what I do want you to understand is that they are a huge lobbying body and have a significant influence on policy decisions in state and federal legislations. That is who is going against PAs. Okay, how does the AMA get this much money? Does it cost that much to become a member? So their website lists several different categories for membership, and if I average all of those fees together, let's say about $200 per person, There are different categories. Some are 60, some are more. So let's just say $200 per person to make it a round number, even though that's not the exact number. You get the idea. And if you multiply that by 270,000 members, you get about $50 million. That's more than what they list, but you get the idea. 50 million out of the 450 million that they get in revenue. So it's just a portion, a small portion. So it's not even close to the $450 million that they receive. They get money from ads in the Journal of American Medical Association, or JAMA, marketing and other activities, such as selling their member information to third parties, and investment income and others. But by far the largest percentage comes from licensure and revenues from the CPT codebook. The AMA owns 100% of the intellectual property of the CPT coding book, and every time it's sent out or someone uses it, they get royalties from that. What this means is that the organization that writes the CPT codes that are used by the U.S. government Center for Medicare and Medicaid Services, or CMS, for Medicare and Medicaid reimbursement also sets the prices for these services. These are also guidelines which most private insurers follow, as it was agreed upon years ago that Medicare and Medicaid would use these as their reimbursement models. So I thought that an organization that writes the codes and sets the price structure, but then profits from their implementation and use, would be anti-competitive, but that's not the case. There have been legal challenges that haven't panned out. Now, how the AMA became the authority and wrote the CPT codebook is another story that I really don't want to delve into. It's not really relevant to this conversation. The AMA has a board of trustees that is composed of 21 medical doctors. Many have other degrees, such as Master in Public Health, Juris Doctor, etc. These 21 MDs guide the organization. Okay, so here we have this huge lobbying organization with a large bank of cash that has a massive influence in federal and state legislation. I intimated in my last podcast that the Scope Creep campaign is not about patient safety, as the AMA says, but rather about market share and money. Now that's my opinion, but I want to share some thoughts with you on why I think that. I also want to explain why I believe the AMA played a significant role in the current physician shortage and healthcare provider shortage, and why with continued spread of misinformation about PA practice, they are blocking a potential solution. You know what? If I were a physician and I joined the AMA, the first thing I would want to do is opt out of their privacy policy. What used to be called the master file, which now goes by the moniker physician professional profile, if it were me, I wouldn't mind it so much if it were used solely for medical boards or graduate medical education programs, hospital credentialing, and similar things. But I want to know who the business partners and relevant third parties are before I agree to let those folks have access to my information. I can tell you this, the PAOS Board of Directors keeps membership information sacred. We would not even think about selling this information to databases where pharma or device companies can target our members. Additionally, we do not allow any other organization access to member information, period. Okay, let's go back almost 30 years ago to 1997 when Congress passed the Balanced Budget Act. Part of this legislation was to cap the amount of money that Medicare paid hospitals for graduate medical education and resident salaries. This limited the number of residency matches. Prior to that, both costs were mostly covered by Medicare and Medicaid. As a result of these caps placed by the Balanced Budget Act, or we will call it BBA, many medical school graduates could not attend a residency program, and many left for international locations to get their residency completed. You know, it's pretty much impossible to practice medicine these days without completing a residency. So, in fact, many international medical school graduates fill these residency spots. There was also a voluntary moratorium placed on medical schools, capping the number to 16,000 admissions per year. The AMA was actually a part of a consortium that reported to Congress there would be a surplus of physicians in the future and recommended these changes. This is one of many reasons why we have a shortage of physicians in the United States today. Ironic, isn't it? I guess they didn't consider the growing population in the U.S. and the growing percentage of elderly patients that would need care. So while the AMA says that they fight for physicians, this policy, in my opinion, seems to be having the opposite effect of advocacy. Let me explain. So, our current healthcare system is anticipated to have a physician supply problem to the tune of 86,000 short by 2036. This is data from a study by the AAMC, the American Association of Medical Colleges, that was published this year. According to the study, approximately 20% of physicians are 65 and older, and 22% are between 55 and 64. It also says that the U.S. population is expected to grow by more than 8% by 2036. So you see, you don't have to be a statistical analysis to see that there are big problems on the horizon. So here's another direct quote from the article, and I'm reading this directly from that article. In addition, the AAMC examined and found that if communities underserved by the nation's healthcare system could obtain care at the same rate as populations with better access to care, the nation would have needed approximately 202,800 more physicians as of 2021. This is more than 5 times the magnitude of current shortfall estimates based on current utilization. Well, let's talk about some of the fallout from the AMA's policy position that predicted a glut of future physicians from the BBA of 1997. You don't have to take my word for it. You can find online the U.S. Senate Finance Committee report from March 12, 1997 regarding graduate medical education. Also, prior to COVID, there are several articles that describe physician burnout. The following bullet points are from the American Journal of Medicine from February of 2020, pre-COVID. First, burnout affects approximately 1/2 of physicians in practice. Second, burnout results in medical errors, lower quality of care, higher costs, and overall worse outcomes. The impact of burnout on the physician workforce is substantial. Burnout is a system problem, not an individual disease, and must be addressed with systemic solutions. We will not achieve the goals of the triple aim unless we add a fourth goal to address physician wellness. Okay, that was pre-pandemic. Now let's fast forward to the pandemic, and physician burnout was reported to be as high as 63%. This is from the AMA, and they now state on their website that the number is below 50%, back to where it was before. And also extremely alarming to me is what the National Institutes of Health termed a silent epidemic of physician suicide resulting from burnout and mental health issues. So the question I ask is, if any of this would be different if we had more providers to see patients? If the AMA hadn't predicted a surplus of physicians in 1997, would we be in the situation we are now, and would physicians be having these issues as significantly as they do? All right, let me recap some of that. Half of physicians experience burnout, potentially resulting in compromised patient safety. While there are many factors that correlate with burnout, including excessive administrative burdens, long hours, and others, I have to believe that if these changes implemented in 1997 under the BBA and supported by the AMA, the workforce shortage would not be as acute as it is now, and this problem would not be as large as it is. That provides a segue to my next point. If burnout is experienced by 50% of practicing physicians, which leads to lower quality of care, why does the AMA steadfastly oppose PAs as a collaborative team member? PAs lessen the burden on physician workloads and expand access to care. This begs the question, can PAs deliver safe, effective care? So to answer that question, I wanted to look at a few studies that were posted on the AAPA. First is a recent article from the Journal of Medical Regulation dated December 2023. Let me read you their conclusion. This study suggests that removing restrictive laws and regulations to PA practice does not increase overall risk to patients or increase rates of malpractice within U.S. healthcare. So the information they got from this study was gleaned from the National Practitioner Data Bank on PA malpractice information. In 4 states that passed PA-favorable legislation reform that allows PAs to practice to their full capability of their license and experience, there was, get this, no measurable difference in malpractice reports from states that did not. Okay, how about a Harris poll that sampled patient responses from 18 states? Now I'm quoting this. For the American population, coordinating and managing healthcare is overwhelming and time-consuming. Not only are U.S. adults spending on average 1 working day per month coordinating care for themselves or their loved ones, but nearly 3 in 4, or 73% of U.S. adults report that in one way or another, the healthcare system is failing to meet their needs. It's broken, folks, and the AMA is a big part of it. The cost of care and time spent waiting for appointments are the most common factors contributing to patient dissatisfaction with the system. And if we look at more from this survey, 93% of adults agree that PAs add value to healthcare teams. 45% strongly agree. All right, here's another study, and this one was from the Netherlands, where they looked at MD only versus PA-MD teams. This is a quote from that study. This study did not find differences regarding length of stay and quality of care between wards on which PAs, in collaboration with MDs, provided medical care for the admitted patients, and wards on which only MDs provided medical care. Employing PAs seems to be safe and seems to lead to better patient experiences. This information about patient satisfaction with their PA experience is also noted from the NCCPA research titled Public Perception of Physician Assistants Report from 2018 and 2022 surveys. I could continue with a lot more research, but I'm telling my colleagues what we already know. PAs provide great care, period. Patients know it, we know it, and our docs that we work with know it. The AMA scope creep is a smear campaign disguised as a patient safety issue. I believe the primary goal is retaining market share. By spreading misinformation and pouring millions of dollars into legislators' pockets, they are preventing PAs from practicing to the fullest of their ability. It should be obvious that PAs can be one of the potential solutions to addressing healthcare shortages of physicians and improving the quality of life of physicians by completing more mundane and basic tasks. You know what? I have a great relationship with my doc, and we have been a team for 20 years, over 20 years. He trusts me that I will deliver quality care to our patients, and when I can't, that I will seek him out for help. This is how it's supposed to be, folks. Unfortunately, in my opinion, the AMA places monetary gain and market share over addressing the healthcare needs of our population. So what do we do? Well, here's my call to action. Educate yourself. Read about this scope creep campaign. There's plenty of information out there. Much of it is on the AMA's website. I invite everyone listening to this podcast to talk to your colleagues. Talk to your docs. I suspect many of them aren't members of the AMA nor know about this campaign. Talk to your administrators. Spread the word on social media. Follow the AAPA and let them know how you feel. Join the PAOS or your relevant specialty organization and let's spread the word. The AMA disregarded the AAPA's request to have a dialogue about this. I believe if we all join in and have a common voice, we will stand to make a change. So this comes to you, listener. Yes, you. You have to do it. Unless you want to see changes implemented where PAs can no longer switch specialties or have a name change, you need to make your voice heard. Do it today. All right, folks, that's all I've got for now. And with more updates, I will let you know more. And look forward to Miles Gilbreth and Chuck Dowell coming on and sharing some of the time on the podcast with me. So you'll be hearing some different voices in the future. And thank you for listening, and thank you for supporting PAOS.